next session will be on thyroid swelling, long case and surgery. And I would request Dr. Utpal Jana sir, Dr. Dipankar Mukherjee sir, and Dr. Pranavashish Banerjee sir to start the session.
So now our thyroid session will start, and just first question, please raise your hand. Those of who will be really happy if you get a thyroid case in your long case. Is there anybody who will be happy or not happy getting a thyroid case in your exam? So nobody is happy, isn't it? Then you have to work a little bit hard on this subject because examination is just there. And we have actually discussed in two major topics. One is history taking and examination, another is surgical management. And before going to that, I will just discuss a few very pertinent points that you must have in your mind whenever you take up a thyroid nodule case. Otherwise, it will be swimming in an unknown vast sea of this subject. So, I just give you a few keynotes on this subject. And you know, these thyroid nodules are an extremely common condition, and it's and these nodules, they can arise either as an hyperplastic reaction of the thyroid tissue, which may have various etiologies, or it may be tumor. And these tumors are again can be benign and the malignant. And the most interesting and the best part of thyroid nodule is that more than 95% of these nodules are benign, be it hyperplastic or benign. It is only these 5% which are malignant, and fortunately these are differentiated. Most of these 5% are again differentiated thyroid cancers, mostly papillary and follicular, and the other one is medullary. Anaplastic or poorly differentiated carcinomas or a lymphoma occurring in thyroid are extremely rare. So, whenever you get a thyroid nodule case, and it is the first responsibility as a clinician that you have to pick up these benign nodules from this vast sea of the thyroid nodules, because these benign nodules really in majority of the time will not need our treatment. And the treatment as of the thyroid nodule is surgery, and surgery of thyroidectomy carries potential hazards and complications that will be discussed later. So, it should be avoided unless it is extremely necessary. So the whole purpose of taking up a thyroid nodule case is to triage these malignant nodules and treat them accordingly. And again, the best part of these malignant nodules is they carry a very good prognosis if you can pick them early and treat them early. For any of our cancers, we always, you know, we talk of about 5-year survival rate, but when it is a DTC, differentiated thyroid cancer, we talk it about 20-year survival rate. So, missing a malignant nodule will be a crime for us, and so we have to be very careful about these thyroid nodules. So, all this I have prepared it in a note form, so you will all get this in the YouTube later. So we have to consider certain points that will actually point us to identifying a malignant nodule. Of which the most important points are age and sex. And you know that nodule in a child or nodule in an elderly patient are more likely to be malignant. In the young and also the middle aged, they are mostly benign. So age is a very important factor, and the sex, the incidence of thyroid nodules are very common, is at least 4 times more common in females than males, but malignancy is more common in males. So when you get a malignant nodule in a male patient, you should be more cautious. Part of likelihood of the past history of neck irradiation, though it is not very important in our setup, but in the Western setup, in the European setup, it is an important point in the history, and we should know it, because till date in Europe and America, they have a substantial population who had a history of low dose irradiation in the childhood or in the young adult for benign lesions like acne, tonsillar hypertrophy, etc. So still they consider this to be a very important point in the history, and And again, last point is important because solitary nodules are more likely to be malignant. So, examining the thyroid clinically and also by ultrasonologically or other imaging centers, whether it is a solitary or a multiple, is very important because many times the other small nodules that are present may not be evident on the clinical examination. But if it is a real solitary nodule, then you must be very vigilant that it can be a malignant one. Rate of growth again, you know it's true for everything, but benign and the malignant nodules both have a very slow growth pattern. So, rate of growth may be very deceptive. So, because it is growing slowly that it is not malignant, do not take it that way, granted. So, try to find out whether it is a malignant or not. If there is a sudden increase in the rate of growth, it might be a bleeding in the nodule, or it might be that a benign nodule, benign pathology now is transforming to a malignant pathology. If and lymph node if is palpable with a thyroid nodule, then the thyroid nodule is almost certain to be malignant, and you know is the papillary variety which is so common and which is also so common presentation with a lymph node in the neck. Toxic nodules again, clinically or scintigraphically or biochemically, if it is a toxic thyroid nodule, then the chances of malignancy is less. So, these are the points, very important points in clinical. Now, the main thing are two actually to delineate a benign from a malignant nodule. One is the ultrasonograph and another is the FNAC. So, first what we do whenever we get a thyroid nodule, we take a history, we examine clinically, we arrive at a provisional diagnosis, and then to convert it to a clinical diagnosis, we send it for an ultrasonography. This is an imaging which is basically in a specialized thyroid clinic is a part of the clinical examination, and it is recommended in the Western literature that USG should be done not by an ultrasonologist, but should be done by the clinician, which is so important. And it is to pick up the malignant ones, and the features in the malignant ones are these 4 points that we have to remember. That is, the nodule will have an irregular margin, the nodule will be hypoechogenic. That means it will not reflect, it will reflect the whole of the ultrasound waves that it is incident on the nodule, it will not pass through it, and it will pass through it, the hypoechogenic will not reflect anything, and we get a dark nodule, or even the nodule may not be evident in the ultrasonic plate, and the nodule will appear as a dark nodule, darkness. When it is taller than wider, it is more likely to be malignant, and if there are microcalcifications. These are the 4 points, those actually point out in the ultrasonography that a nodule will be a malignant one. And the American Imaging Association, they have actually designated 1 point for each these points and 2 points where there is a marked hypogenicity. That is almost the nodule is invisible in the ultrasonographic plate, and they have actually formulated what is called a thyroid imaging, reporting and data system, and they have tried to classify and they have described 5 or 6 type of thyroid points, and they have tried to classify and the malignant ones. So, this is important, and you must know if you have to face a thyroid nodule case either in your practical or in the oral table or even in the theory. So, these 5 are described, 1, 2, 3 are all benign, and but this 4 is malignant, and they have made 4A, 4B, 4C. So, I am not going into the detail because it is not so easy to remember just by listening to one. This will be all in the slides. So, please go through in detail. So, when you get a report from the ultrasonologist that it is thyroid 4, that means it is a suspicion of a malignancy. A will be a low suspicion, B will be an intermediate suspicion, and C will be a moderate suspicion. And when it is 5, that means it is confirmed. 6 is added separately, that is your ultrasonologist will give it a thyroid 6. When you have actually diagnosed, you have sent the diagnosed case of thyroid cancer to them for the ultrasonographic recording of the features. So, but please read it critically and remember it for not only your exam but for your future life also. This is a statistical data that is important. You may just look into it, that these 4A, B and C, they constitute the maximum positivity of malignancy. But that does not mean that the 3 or 5 is 100% leave it. The 3 also carries a positivity rate of about 3%. So thyroid 3 may not be always very benign. So you have to mix it with your other modalities to again select it whether it is a malignancy or not. Now the next investigations that you all write in the OPDs, I know, sent is an fine needle aspiration cytology. But before that, a point, because still a little senior examiners or senior clinicians, they can talk about the needle biopsy. Needle biopsy has this advantage that it will pick up a more tissue, so it will give you histological diagnosis, but it is not nowadays because of these points, and of which the most important is tumor implantation and inability to detect capsular and vascular invasion. And this is very important because follicular carcinomas can only be diagnosed if a vascular invasion is demonstrated. So these are the reasons, and bleeding, nerve injury, tracheal perforations are all procedural complications that may occur, but this is not popular, it is not used. Important is FNAC, and you have to know a lot of these FNACs. These are all theoretical points that I have mentioned, but what is the most important is American Thyroid Association designed the Bethesda classification to pinpoint or pick up the malignant nodules, and that you must know, because even the FNAC report will come as a Bethesda score to you. You must interpret this Bethesda score. And secondly, the follicular carcinoma cannot be diagnosed, because again for the same reason that it cannot demonstrate a vascular invasion. But for papillary carcinoma, it is almost 100%. It has a sensitivity is almost 90% for papillary carcinomas. So this is Bethesda classification. There are 6 varieties described: Bethesda 1, 2, 3, 4, 5, 6, of which Bethesda and what is the management, the typical management for Bethesda that you also have to know. As in Bethesda 1, it is a non-diagnostic, because the from material nothing can be diagnosed. It is a cyst or no tissues or no cells in it, but even it has been seen that these cases carries a risk of 5 to 10% of malignancy. So whenever you get a Bethesda class 1 report, you should go for a repeat FNAC. But Bethesda 2 is benign. Bethesda 2 is benign. The cytology is definite from the cytological features, not malignant. But again, in a long follow-up, 3%, and the statistics have shown up to 3% can be a malignant. So you just don't leave it like that. You have to follow it up clinically and ultrasound USG, and again repeat your investigations the moment you start or you you be suspicious about a malignant transformation. But what is the most tricky is the Bethesda 3, because Bethesda 3, it is the malignant features are not there. There is atypia of undetermined significance or follicular lesion of undetermined significance, but they carry quite a high rate of malignancy. So in these cases, it is really it is really a conjecture, and what are recommended is either a repeat FNA, and even repeat FNA may not be very guiding. So then molecular testing. Molecular testing is now has come to the Bethesda guidelines by the American Thyroid Association 2015. But unfortunately, here we don't have the facilities. But we must learn it, because there may be some examiner who may want to know from you, or it may be that tomorrow we will have the facilities to do it. Diagnostic lobectomy again, I think Dr. Banerjee will pick up how pertinent to go for a diagnostic lobectomy. But if you do a diagnostic lobectomy, you can definitely confound. So Bethesda 4, it is actually again like Bethesda 3 and same diagnostic lobectomy or molecular testing that has been recommended, where again the suspicion is very high. It is for the follicular neoplasms because you cannot demonstrate a vascular invasion. Bethesda 5 is suspicious of malignancy, where we do a total thyroidectomy or a hemithyroidectomy, where malignancy is quite high, and Bethesda 6 is confirmed malignancy. Okay. So just a few points about the molecular testing. Is fortunately from these few cells that are aspirated during FNAC, a molecular diagnosis, a genotyping is possible, and finding any of the following panel of mutations that provide strong indication for malignancy and help in indeterminate psychology. So these are these mutations that actually has been found in malignant nodules. I am not going into detail, some for the papillary, some for the follicular and all, and this molecular diagnosis has been included in 2015 revised ATM management guideline in patients with thyroid nodules with indeterminate cytology. So please keep in mind and remember the molecular testing in thyroid nodules. So now coming to the principles, it is surgery. Surgery, and it is either total thyroidectomy or hemithyroidectomy, lot of conjecture, lot of debate, very interesting debate. We can do it if you get free time after all this is finished, because central compartment clearance, again it is a point of debate. Central compartment, you all know, it is the level 6 from the higher carotids on two sides and a straight line that passes from the right innominate artery to the left innominate artery. So all the fibrofatty tissues has to be removed because thyroid mainly drains into these nodes. But it is again a point of a debate that whether when there are nodes there is no debate, you have to do it. But when there are no nodes, whether you go for a prophylactic or not prophylactic, again if you want we can discuss in our free time, because it's not, I think, necessary for your exam. Follow up is not just do a surgery and let the patient go. Follow up for the whole life is very important. I am not going into the details of the follow up again for the want of time. Where there are in the follow up, you have to detect whether you are left behind any amount of tissue, and if there is any amount of tissue, then radioiodine ablation of the residual, and again then follow up for the rest of the life. And radiotherapy is reserved for unresectable tumors. It has no great role in the thyroid treatment. Chemotherapy, yes, no role. These are the surgeries that are done, I have just discussed. And about the lymph node dissection, still there are authors who recommend berry picking. Berry picking means not going for radical clearance, but just remove the enlarged nodes. And it has been shown statistically that the both groups where you do a radical clearance and where do berry picking, they have the same survival rate and same recurrence rate. But what is most important in thyroid surgery is saving the nerves. It is remove the thyroid, but don't remove the recurrent angina, the external branch of the supralaryngeal or the parathyroid, because removing these nerves actually you make the patient a permanent and wretched handicapped person. So the surgery of thyroid is all about saving these three important nerves and removing the whole of the thyroid. So for the parathyroid, actually if you just retain one parathyroid, permanent hypoparathyroidism in long run does not affect. But if you remove more than one parathyroid, the chances of a transient parathyroid in the immediate hypoparathyroid, the immediate postoperative period has been observed, but that can be managed. So you try to save all the four parathyroids is very important functionally and also structurally, because you never know that the one parathyroid that you have saved and removed all the three are viable, because you may be on the process of your dissection, you have jeopardized its vascularity. So it is very important to identify the parathyroids. It is very difficult. Very small pink oval structures, 4 are there, very difficult to identify, very much confused with a lymph node if it is there, is the thymus if it is there in the inferior pole, or even a big flat globule. So there are ways, and I will just tell you 1 or 2 points that how you can actually identify these parathyroids. That actually these parathyroids, they are identified by its anatomical position, by its color, and they are best confirmed by its following its vascularity. These parathyroids, they get their vascular supply from the inferior thyroid artery, and so while while dealing with inferior thyroid artery, as we used to previously say, that we clamp the inferior thyroid artery from away the thyroid gland, so that we can save or protect the recurrent angial nerve from getting clamped in it, will jeopardize the vascularity of the parathyroid gland. So we have to identify the inferior thyroid artery and identify the slender arteries that are going to the parathyroids, and if you follow, you can see the parathyroid. This is the best way. Very difficult in the naked eye, particularly when the thyroid is very big, when illumination is not good, and so most of the authors, they recommend taking a magnification at this step, either a loop or a microscope. So and a damaged devascularized gland, if there, it turns black. So if you ultimately find the parathyroid, but it is not pink, it is black, that means you have damaged it, and if you leave it, then it will have no purpose. So immediately you have to take it out, you have to slice it, and then take it in a syringe and inject it into a styroid muscle. Sternum is very handy in this. So actually there are many methods, of which what I told you is the most practical method of identifying the parathyroid, but there are many other methods that I mentioned, but you just remember it as a point for your exam only. And what is another important thing is to remember is that the terminal these arteries to the parathyroid, they are end arteries. So you must keep in mind, you cannot damage this vascularity of the parathyroid, sorry, you actually damage the parathyroid then. So these are all methods. I am not going into detail, you just go through the note theoretically. Another is the external branch of the superior laryngeal nerve. And as you know that this external branch of the superior laryngeal nerve, they arise above and passes downwards on the lateral side of the thyroid, and ultimately supplies the thyroid cartilage over the inferior constrictor muscles and supply the cricothyroid muscle. So we actually search this external superior laryngeal nerve in its anatomical location, and it's again a few triangles are described in the thyroid bed. Of one is the Jones triangle for this external superior laryngeal nerve, which is described as the upper attachment is the attachment of the sternocleidomastoid muscle on the hyoid, lateral is the superior thyroid vessels and upper pole of the thyroid gland, and medial is the midline. And in this triangular space, the Jones triangle, it is usually the superior laryngeal, external branch superior laryngeal nerve can be seen, very slender nerve, so you have to be very careful about it. And it's called, and the cricothyroid space of Reeves is described as an avascular space that is medial to the superior pole of the thyroid and to the cricothyroid muscle, and it is on this avascular space we actually get the nerve. So if you retract the superior pole of the thyroid, this is avascular space, and search for it, we get this superior laryngeal nerve. But many times the superior laryngeal nerve is not visible, because on its way downwards over the inferior constrictor muscles, it can be totally go medial to the inferior constrictor muscles and hidden there. Now this is again a very important relationship that's called the Sarnia classification, where actually, and this is followed by most of the surgeons, three relationships have been described as the type 1, type 2 and type 2B, where in the type 1 the external branch is seen at least 1 centimeter above the upper superior pole, and type 2B is within 1 centimeter, almost near the, or it is just in posterior to the upper pole, and type 2A is within 1 centimeter. It is the type 2B type which is most vulnerable. So all these points that we must keep in mind when we actually dissect the superior pole of the thyroid. So individual ligation of every branch of superior thyroid artery. Usually what was taught that it is en masse ligation of the superior thyroid artery on the upper pole of the thyroid that can prevent injuring the nerve. But no, in the type 2B variety, it will definitely be caught there. So individual ligation of the superior branches of the superior thyroid artery and almost at the capsule of the superior thyroid prevent the damage to the superior external branch of the superior laryngeal nerve, even if we do not identify it. And it has another great advantage, that it also preserves the posterior branch of the superior thyroid artery, which is supplied to the superior parathyroid again. So this is very important, and attempting to visualize before this report and use of intraoperative nerve monitoring and visualization of contraction of the glucothyroid muscle, theoretical points for your theory answer if needed. The other is the recurrent laryngeal nerve. Again, you know its anatomy, I am not going into it, but in the right side and in the left side the courses are a bit different. In the left side it actually recurs on the arch of the aorta and gains the tracheoesophageal groove much below and runs parallelly upward, but on the right side it is the root of the neck, it is the right subclavian artery that it hooks and gains the tracheoesophageal groove in an angle, and so it is more vulnerable, and its relationship with the inferior thyroid artery is very important to understand to save this artery during the surgery. So it is for the inferior thyroid artery, it is posterior to the inferior thyroid artery in the majority of the cases. It can be anterior to it, or it can pass through the branches. So whatever it may be, what is most important is identifying the recurrent laryngeal nerve. You should never go for clamping the inferior thyroid artery branches without identifying the nerve, or else you may definitely injure the nerve during the surgery. It's another very important is Berry's ligament, and you have now thyroidectomies are done very frequently. It's a common disease. So you have seen that the recurrent laryngeal nerve goes very close to the Berry's ligament, and while dissecting the Berry's ligament, as it harbors the artery, every time it bleeds, and if you are not very careful on clamping the this artery, you may clamp the recurrent laryngeal nerve. So Berry's ligament, it is just 3 millimeter, within 3 millimeter usually, and sometimes it may even pierce the Berry's ligament. So you have to identify before taking this test. And it's a very interesting paper by a person called Sinde, who had measured the angulations that the recurrent laryngeal makes with the tracheoesophageal groove. Is also important to keep in mind. On both sides, the commonest, it actually takes the tracheoesophageal groove in 15 to 30 degrees, but in the right side it may take in 30 to 45 degrees. So that's going 45 degrees, it means quite vulnerable to when you are actually clamping the inferior thyroid artery. 0 to 15 degrees almost parallel in the left side, that you have also seen during surgeries, I think. Again, its relationship with the cricothyroid articulation at the upper end. At the upper end, what is most important is the recurrent laryngeal nerve may branch into anterior and posterior branch before entering the larynx, posterior to the cricothyroid joint, and it actually gains the cricothyroid joint in angles of regarding on the right side 15 to 45 degrees and the left side 0 to 30 degrees. So in this area, you must be careful that the nerve is not just running up parallelly and going behind the cricothyroid articulation, it is making an angle. And when this tubercular Zucker candle is present, you have seen it is in the posterior surface, in the posterior medial surface, you usually get this nodular swelling, which is embryologically basically is the fusion of the ultimobranchial body and the median, it's called the median process. So if it is present, the nerve can be easily found medial to it. So these are very important relations that we must take into account. And this variant non-recurrent nerve is present in only 0.251%, but it can be present where it is actually arising from the vagus nerve and going perpendicular up in the middle of the neck to the larynx, and if you are not careful, then you can damage it. So actually this occurs, you may know, it's interesting theoretically, this occurs that when the right subclavian artery has an aberrant origin medial to or left of the left subclavian artery from the arch of the aorta. The human communicating nerve is not important, it's just cavity. And a few triangles that you also should be keep in mind. One is the Simon's triangle. These are the triangles that actually describe the anatomical location of the recurrent nerve. Simon's triangle, the common carotid artery laterally, esophagus medially, and inferior thyroid artery superiorly. So in this triangle, the recurrent nerve will be found. The lower triangle is again another triangle that is described similarly, medial border by the trachea and esophagus, lateral border by the carotid artery, and superior border by the surface of the inferior pole of the thyroid. But the most important triangle is the Simon's triangle that most of the surgeons follow, and the last is the Bayes triangle. So actually talking about thyroid never ends, it is such a vast subject. So we have definitely very paucity of time. Two more important points are left. So now I hand over to Dr. Jana, and if you get some time after the end, we can discuss anything. Thank you, and wish you best of luck in your next exam, and I hope you will all do very great and pass out very successfully, and somebody get a thyroid case also.
Good morning, everybody. First, I like to thank our organizations, AOIWV, for arranging such classes for the postgraduates. It is very important, and also I think it is very important for the teachers, because we have also a scope to prepare ourselves for the examining also. This is very important. So the history of Dr. Mukherjee has elaborately discussed the salient points of thyroid. So just the history, how to take a history, you have know already the history, how to take a history and what parts to be examined. Just a salient points. So before going to history takings, I like to highlight some general points of history taking. Apart from clinical examinations, history taking is the most important part of patient's investigations, because there are so many diseases where there is no organic pathology, only the history is important for diagnosis, and history will tell which parts to be examined carefully. There is so many examination parts, but history will suggest which part should be examined carefully. That we can gain from taking the history. And apart from this, the most important thing, in my opinion, that history builds a relationship with the patients, and this is the most important thing, on which all the treatment is depending. Some patients I am examining patients, but sometimes the patient, after visiting my chamber, will go to your chambers, and we talking with you, they will be impressed. So this doctor may be cure myself, and not sir, cure myself. So this is the importance of history. So, and when you are taking a history, it should be a very cordial, very friendly, and it should not be mechanical. Mechanical means usually we follow a sheet, and what is your name? You write the name. What are the chief complaints? You write in the chief complaints. This is a mechanical one. History means it is the story of the disease. So you will take the story of the disease, and it may be that you are taking the chief complaints letter after taking the family history. So this may be the approach for, and you will provide importance to the patients, and you will hear the patients carefully, and you will be empathetic during the history takings. So these are the most important thing for history taking. And in case of a thyroid history, the thyroid problem is maybe a benign nodule, a malignant nodule. The patients may be hypothyroid or a hyperthyroid. Though hypo and hyperthyroid is not in our domain, but the patients will come as swelling. Patient may be hypothyroid, may be hyperthyroid. So it is our responsibility to sort out the patients and to refer the patients to some other specialty, or we can take for surgery. So we have to know all the things. The patients first coming to us with the neck swelling. So during history taking, particular of the patients, next the chief complaint swelling, as usual, pain over the swelling is very important. Sometimes the patient may be thyroiditis. So patients that pain over the swelling, hoarseness when there is a voice, laryngeal nerve is involved, difficulty in swelling, sometimes a very large goiter reaching the esophagus, difficulty in breathing, also very large or retrosternal goiter, bulging of the eyes and trembling of limbs. These are findings for the hyperthyroidism. So along with the patients may be with some mixed edema facies or pre-tibial edema or a lethargic or a cold intolerance or cold hypotolerance. So these are the symptoms you have to be asked during a thyroid case. So history of present illness, usually history of present illness, this is the elaboration of the chief complaints and also taking the associated symptoms or important negative symptoms. So swelling, the duration, onset, progress, pain, the duration, site, character, radiation, aggravating and relieving factors, you all know it, difficulty in swelling, difficulty in breathing. Sometimes the thyroid cancers with bilateral recurrent laryngeal paralysis may comes with respiratory distress. That is a very difficult situation. Symptoms of hypo and hypothyroidism like appetite, weight loss, bowel habits, palpitation, insomnia, trembling of limbs, sweating, intolerance to heat or cold. History of present illness, also the bulging of eyes, duration, progress, redness, double vision or loss of vision. And examinations, during examinations definitely, during general survey, we will particularly give importance to the face, the pulse and the neck glands. Neck glands we also examine during the examination of the swellings. The local examinations, all the 4 parts, that is the inspection, auscultation, inspection, palpation and percussion and auscultations. These are the 4 main ways for examining a patient. So all should be done in case of thyroid swellings, like inspections, position of the patients, shape, size, surface, margin, skin, pulsation, movement with regulation. This is very important. Thyroid swellings, and sometimes thyroid swelling is better diagnosed by inspection than palpations. Movement of swelling with protrusion of tongue and any venous prominence over the neck, which may be seen in retrosternal goiter prolongations. So palpations, same things. Also with palpations, we have to note the surface margin and consistency. There is a pulsation of fill, this mainly and mobility and skin fixity. Position of trachea, larynx, sternomastoid muscle. This is very important. Test for tracheal compression. This is called Cocker's test. Cockers are the important surgeons in thyroid surgery. Why? Can you tell? You know the Cocker's artery forceps. Before the advent of Cocker's surgery, there are lots of death in thyroid surgery. Yes, and Cocker's described the techniques, modern techniques of thyroid surgery, and the death rate is reduced. And for this, he got Nobel Prize. Yes. So Cocker's an important persons for our thyroid. Position of trachea, test for tracheal compression, Cocker's test. If we press the trachea, if we press the thyroid swelling, the patients will complain respiratory distress. Carotid pulsation, this is also important. In case of malignancy, there will be loss of the parotid pulsations when the carotid artery is engulfed by the thyroid mass. and looks for Horner syndromes, this may also be present. So examination, percussion over the sternum, usually it is resonant, but when there is a retrosternal prolongations, you can feel it is a dull in feeling. Osculations of the bruit near the upper pole, it can be seen in Graves' disease. Cervical lymph nodes, usually in malignancy, and toxic signs, usually toxic eye signs, you also note for these ones. Look for the chemosis, diplopia, movement of eye, retrosternal prolongations, Pemberton signs. I am coming to the later. Systemic examinations, all systems should be examined carefully, especially the cardiovascular systems should be given proper importance. Next, case summary. The case summary, when you present a case summary, it is to tell a short history of the patients with the positive findings and also the important negative findings. Sometimes these negative important findings gives a proper clue to diagnosis. Okay, so these are the very important. So usually a 35 years female patient presented with a swelling in front of the neck for last 2 years, which was about the size of a marble when she first noticed. Since then swelling is gradually increasing, but she denied any history of rapid increase in size. She has no difficulty in breathing and swallowing, and there has been no history of change of voice. These are very important. No history of change of voice. Patient has no other systemic symptoms. By this, you can exclude that the patient has no hypothyroidism and there is no chance of malignancy. So on examinations, general survey is normal. On local examinations of the neck, there is a swelling in the right side of extending medially to about 1 centimeter to the left of the midline, laterally extending to the border of the sternomastoid. Usually during, usually during description of the swellings, we laterally sternomastoid muscles, anterior border of the medial or lateral border, suprasternal notch or the sternoclavicular joints, and above the thyroid cartilage or the thyroid cartilage. These are the landmarks we take for considerations. So the swelling moves up with deglutition but does not move with protrusion of tongue. The swelling is globular, margins are rounded, overlying skin is normal, firm in consistency and is free from skin and underlying structures. The carotid pulse is palpable and there is no toxic signs and clinical evidence of retrosternal prolongations. So this is a case of non-toxic solitary thyroid nodule involving the right lobe of thyroid. This is given here. If you write it, it is very easy to write during examinations, because if you think what should be written during examinations, it may take time. So if discussions, how will you palpate? You all know it. How will you palpate the thyroid gland? Main important thing is that whenever you palpate the thyroid gland, it should be made prominent. So if you push it from this side to this side will be, left side will be prominent, and you can palpate it may be from behind, it may be from front. The main thing is that it should be made prominent. Okay. If you push from left to right, then the right side would be palpated. And when there is a very small, you can make like this. Okay. So this will make most of the gland prominent. So this is the most important thing during examination. So it can be, there is a Lahey's method, also left lobe, okay. Next, from back also be palpated. These are the pictures. Discussion. What is Pigelos method of palpations? It is obvious patient. It is also the same things to make the gland is prominent. What is Kryl's method of palpation? Some small swellings of thyroids are palpated by pulp of the thumb, and patient is asked to swallow. So, okay, just one finger or thumb, pulp of the thumb, we can palpate very small one. What is Berry's signs? Carotid pulse could not be palpated. It is found in malignancy. The eye signs, this is very difficult to keep in mind. So you can write it and note it, no problems. But it is usually not asked during any ENT examinations. This is more or less a medical field. But some examiners may be fascinating to some medical points and may ask you, no problem. It may ask you, have you seen the eye signs? Discussions on examinations, which thyroid swelling does not move up with deglutitions, nephritis, CA thyroid, local infiltrations, thyroiditis, renal thyroiditis, huge goiter, when it is impacted into the suprasternal notch, inlet of thorax, and retrosternal prolongation with intrathoracic impaction. How do we assign clinically retrosternal? A history of respiratory distress, swelling of face, engorged veins, lower margin could not be palpated, dull on percussions, and the Pemberton signs is positive. The patient is asked to raise both hands, touching the ears, and keep for 2 to 3 minutes. Congestion of face, engorgement of neck veins, and respiratory distress may be noticed. So these are the points to be noted to note retrosternal prolongations. This is science. So what are the possible diagnoses in basic sense? I think this part will be taken by Dr. Pranashis Banerjee. Okay, thank you.
Hello, good afternoon. So, starting from where Jana sir has ended up, so this is where Jana sir ended up, that this is a sort of case which you are going to get in the examination. So, there is a 32-year female. This is the history: insidious onset and gradually progressive swelling, slightly to the right of midline for last 6 months. Oval shaped swelling 3 by 2 centimeter. As Jana sir re-emphasized, moves with deglutition, no movement with protrusion of tongue. You are going to mention the surface, the margins, the consistency, the temperature. Temperature is to be appreciated by the back of the fingers rather than the pulp of the fingers. The examiners are going to see that. The swelling is non-tender, non-pulsatile. There is no clinical feature of hypo or hyperthyroidism. Now, so what are the differential diagnosis of this thyroid swelling? So when you are being asked this question, I have framed this in the question answer form because in your exam you will be asked the questions and you are supposed to answer. So what are the differential diagnosis of solitary thyroid nodule? Thyroid cyst, it can be a localized form of thyroiditis, it can be a dominant nodule of a multinodular goiter. Now when you are getting a thyroid swelling, there are three possibilities rather. You are getting a thyroid swelling, rather whole of the thyroid gland is enlarged. It can be a diffuse goiter, a colloid goiter. If it does not show any features of toxic signs, it is a non-toxic multinodular goiter. If it shows signs of toxicity, it is thyrotoxicosis. This is the first scenario. Second, you are getting a single swelling. So that can be a solitary thyroid nodule, which may be a dominant nodule or an isolated nodule. Now, what is the meaning of dominant nodule? Dominant nodule means the overall gland is nodular, out of which a single nodule is clinically well appreciable. Solitary thyroid nodule means overall the thyroid gland is not palpable and you can appreciate only the thyroid swelling, a small nodule, right? So it can be a multinodular goiter, it can be a toxic nodule, it can be a solitary thyroid nodule, it can be a dominant nodule. The other differential diagnosis may be, it can be thyroid adenoma or carcinoma, which we will discuss later on. So what do you mean by solitary thyroid nodule? By definition, it's a discrete thyroid swelling in an otherwise impalpable thyroid gland. So what does that mean? When you are asking the patient to deglutate, you can see a small swelling moving in that area where the thyroid gland is present, which implies that rest of the thyroid gland is not clinically appreciable and you are palpating, you can inspect a single swelling, suppose in the upper pole of the thyroid gland, right? So this can be of two types. As I mentioned, it can be a solitary nodule or it can be a dominant nodule. The prevalence is 4 to 7% of the adult population. However, if you do ultrasonography, you can appreciate that in 50 to 60% of the population, female is to male ratio is 4:1. So how will you investigate a solitary thyroid nodule? Your answer should be, my investigation depends upon three things. Number one, radiological evaluation. Number two, pathological evaluation. Number three, biochemical evaluation. The radiological evaluation by number one, USG. Number two, X-ray soft tissue neck lateral view. Number three, CT scan if required. Number four, thyroid scan if required. No mention about FDG or PET scan preliminary. Number two, pathological evaluation, USG guided FNSC. Third, biochemical evaluation, thyroid profile, thyroid peroxidase antibody if indicated, anti-TG if indicated, molecular markers rarely indicated in our scenario. So primarily, high resolution sonography by radiological evaluation, USG guided FNSC pathological evaluation, and basic thyroid profile, that is the biochemical evaluation. So this is the chart which is mentioned in our standard textbooks, not going into the details because the overview have been given by Dipankar Mukherjee sir. So what are the different information that we get from USG? As sir was saying, so this is hypoechoic mass. This one is isoechoic with calcification. So what are the different information that we get? Number one, whether the swelling is cystic or solid. Cystic nodule is less of premalignant, solid nodule is more of premalignant. However, there can be some solid nodule surrounded by cystic changes. Second, if it is a multinodular goiter or it's a solitary thyroid nodule. Third, as I mentioned, if it is isolated nodule versus dominant nodule. Fourth, if lymph nodes are present, whether the lymph nodes are having benign features or malignant features. And fifth, calcification, which may be of 4 types. We'll just discuss. So, as sir has mentioned about the thyroid score, we'll not go into the details. Just a small thing, you can remember the mnemonic CESCM, that is calcific composition, ecogenicity, shape, margin, and calcification, C, E, S, C and M. This is how I remembered this. So, this is about the thyroid scoring. Composition, solid, cystic, spongiform, mixed. The maximum weightage is given to the solid nodule, that is a weightage of 2. Second, ecogenicity, it can be iso, hypo, anechoic, hyperechoic, very hypoechoic. Very hypoechoic is given a weightage of 3. Now, ecogenicity will be asked is compared with what structure? Ecogenicity is compared with the ecogenicity of the strap muscles. So, if the ecogenicity of the nodule is less than that of strap muscle is hypo, otherwise it is hypo or hyper. Shape, as sir mentioned, taller than wider. Margins can be smooth, irregular, ill-defined, extrathyroidal extension. Now, there is a bit of difference between irregular margin and ill-defined margin. Ill-defined margin means the margin of the nodule merges with the periphery, right? Merges with the surrounding thyroid parenchyma. That is ill-defined margin. An irregular margin means it is well defined, but the margins are irregular. So, irregular margins are more premalignant rather than the ill-defined margin, though extrathyroidal extension is given the maximum weightage of 3. Calcification can be of 4 types. I have got a picture. Yeah. So, if you can see this, these are the punctate microcalcification, right? If the calcification is present in the periphery, this will be peripheral rim calcification. If there is a huge calcification inside, then that will be macrocalcification, and no calcification is the comet tail appearance. So, punctate microcalcification is given the maximum weightage. So, this is about the USG finding. Depending upon this, the thyroid score has been given, where TR5 is highly suspicious, TR4 is moderately suspicious, and TR3 is mildly suspicious. Going to the next topic of discussion, that is the FNSC. Sir has mentioned in detail about the Bethesda, so I am not going into the detail of Bethesda staging. Point to remember is that most of the cases where we get some dubious result is that of Bethesda 3, that is ATP of undetermined significance or follicular lesion of undetermined significance. In these cases, you can neither go for surgery immediately, nor you can go for wait and watch policy. So, better to go for lobectomy. In rest of the cases, the treatment protocol is obvious. After you have examined the patient, you are supposed to give a clinical staging of the thyroid swelling if you are suspecting that it is malignant. So, just remember that for all head neck malignancies, as you have been already discussed, the staging follows a definite protocol. T1 is always less than 2, T2 is T2 4, T3 is more than 4, T4 is outside the domain of the primary site of origin. This is the basic TNM for all organs in the head neck. In thyroid, you can further subclassify the T1, T1A and T1B. This T1A means the size of the primary is less than 1 centimeter. T1B means the size of the primary is more than 1 centimeter. But why this has been subclassified? Because T1A lesion behaves more like a benign lesion rather than a malignant lesion. So, T1A less than 1, T1B more than 1 but less than 2. T2 remains the same, that is more than 2 but less than 4 centimeter. T3, when we studied, we had only known T3 means more than 4 centimeter limited to thyroid gland, right? However, a small thyroid swelling, small nodule, say 1 centimeter, if it is present close to the surface of the gland, may immediately invade into the surrounding strap muscles by invading the capsule. So, naturally, it cannot be T1. Hence, such swelling of any size which invades into the surrounding strap muscles is being upstaged to T3B. So, what is T3? T3 can be divided into T3A or 3B. 3A means more than 4 centimeter, intrathyroid. 3B means of any size which invades the adjacent strap muscle. T4 means it has gone outside the thyroid gland, further divided into 4A and 4B. 4A means structures just adjacent to the thyroid gland are invaded, like trachea, esophagus, recurrent laryngeal nerve, larynx, right? These are the structures in the immediate vicinity of the thyroid gland. Hence, T4A is trachea, esophagus, recurrent laryngeal nerve, larynx. 4B means structures which are invaded actually makes the condition inoperable. theoretically inoperable. What are the structures? Prevertebral fascia, mediastinum and carotid. So this is how you remember the thyroid staging. T1 less than 2, 1A, 1B. T2, 2 to 4. T3, 3A and 3B. 3A means inside the thyroid, 3B means just outside the thyroid involving the strap. And T4, 4A and 4B. 4A means structures adjacent to the thyroid, trachea, esophagus, RLN, larynx. And 4B means which has gone beyond the local invasion, that is prevertebral structures, mediastinum and the carotid, right. Coming to the, coming to the N. This N staging of all head neck malignancies are same except for two. Number 1, nasopharynx. Number 2, thyroid. So for thyroid, the N is very easy to remember. It is N1, N0. Obviously, there is no evidence of regional lymph nodes. And N1. N1 can be divided into N1A and 1B. 1A means the lymph nodes which are in the immediate vicinity of the thyroid gland. That is the level 6. What happens to level 7? Level 7 gets direct drainage from level 6. So level 7 is not in level 1B, but level 7 is in 1A. 6 directly goes into the 7, into the mediastinum. So level 6 and 7 is 1A. Lateral lymph node involvement is level 1B, that is level 2, 3, 4. M0 is no mets, M1 is metastasis present. So these are the prognostic factors which Dipankar Mukherjee sir had mentioned. Now coming to the treatment. After the investigation, let us discuss in this slide. Let us not look at those slides, right? So these I have drawn 5 scenarios which will help us in discussing about the management proper, right? All of us have read, all of you have already read. So this is first scenario. This is a thyroid swelling 2 centimeter by 2 centimeter involving the right upper pole. Is it visible to everyone? Involving the right upper pole. Bethesda is 5 or 6. It is suspicious of papillary carcinoma. So clinical staging in this case will be, it is either T1 or T2, right? N0. What will you do? When we were the students, initially we read that papillary carcinoma is known for multicentric, multifocal, bilateral character. What does that mean? If the tumor is in this lobe, it can easily involve this lobe. How? By intrathyroid lymphatics, which runs from one thyroid gland to the other thyroid gland. So in those days, less than 1 centimeter was conservative, more than 1 centimeter was, you have to go for total thyroidectomy. This was what we read many years before. But now, for this structure, this case, we have to go for only hemithyroidectomy. We are going to remove only the right lobe of the thyroid gland. Second scenario, I am coming to the lymph nodes later on. The size is 3 centimeter by 3 centimeter. Then that means it is definitely a case of T2 lesion, right? T2, N I have not mentioned, MX. In this case, again you have to go for hemithyroidectomy. However, there are certain circumstances in which you are not going to do the hemithyroidectomy, rather than you have to go for a more aggressive surgery. When? Number 1, if during surgery you find that that nodule or the tumor is coming close to the surface of the strap muscle. Radiologically, they have said that strap muscles are not involved. However, when you are doing the surgery, you find certain adhesions between the surface of the thyroid gland and the strap muscle, which implies that there might have been some invasion. In that case, obviously, the tumor is upstaged to T3B, and hence you have to go for total thyroid. Number 2, patient does not have hoarseness of voice. However, when you are dissecting the tumor or the thyroid gland, you are finding that the tumor is situated in the posterolateral aspect of the thyroid gland, and hence there is every chance of involvement of the trachea or the esophagus or the recurrent laryngeal nerve. Hence, in that case, you have to go for the total thyroidectomy. Third, USG finding has not revealed any neck node, but during the surgical procedure, you find that there is something central node. If you are getting a central node which you suspect to be malignant, in that case, obviously you have to go for total thyroidectomy, right? So this is scenario 2. Scenario 3, you are getting multinodular goiter rather than a solitary thyroid nodule. In one side, it is 2 by 2, Bethesda 3. In the opposite side, it is Bethesda 2 and Bethesda 5, which implies that this might be definitely malignant. If this is a malignant and there are nodules on the opposite side, it implies that the opposite lobe might have been involved, which has not been picked up by the FNAC. So there is no point in keeping the opposite lobe and removing single lobe. You have to go for total thyroidectomy, right? Now, coming to join up the lymph node stature, right? So, in the first case, patient is having N0 neck, right? Conventional treatment was you go for elective neck dissection, that is the central compartment neck dissection. Jana sir has done central compartment neck dissection in this case. I have not done because I don't know how to do the central compartment neck dissection. After 5 years, how will the case progress? In my case, in which I have not done the central neck, there is 2% chance of development of the neck mets, which implies that the chance is not, there is not statistically significant chance, right? Which implies that you can, now if the central compartment is done, it adds up to the morbidity of the primary case. So elective neck dissection is actually a matter of controversy. Am I clear? The protocol is, if the patient is having N0 neck, elective neck dissection can be done. However, elective neck dissection is controversial. So you better do only hemithyroidectomy in this case. However, if you get a central node, either radiologically or during the course of surgery, central neck dissection has to be done. Second thing, if you are getting a central neck, there is every chance that the lateral neck will be involved. If you are doing the lateral neck, which lymph nodes are to be removed? 2, 3, 4, right? You are not going, you may leave the 1A, you may leave the 1B, you may leave the 2B. 2B is above the spinal accessory, right? You can remove 2, 3, 4 and even 5A. So lymph nodes which can be spared during lateral neck dissection in case of thyroid surgery are 1A, 1B, 2B and 5B, right? 2B is the topmost above the spinal accessory, 5B is the lowermost in the posterior triangle, right? So this is about the controversies regarding neck. Fourth scenario, you are getting a case where it is a 5 by 4 centimeter thyroid swelling. Obviously it is T3, right? If it is a T3 or T4, you have to go for directly total thyroidectomy. This is a very interesting scenario where I am going to spend some time. You have removed the thyroid swelling. The preoperative FNAC was actually inconclusive, what happens in most of the cases. Post-op biopsy has come out as medullary carcinoma of the thyroid or MTC. What you are going to do? If you get a patient with MTC post-operatively, first you have to genetically screen the patient. MTC is having 3 types, MTC 2A, MTC 2B and familial MTC, right? If you are getting MEN 2A, you have to exclude pheochromocytoma as well as parathyroid gland hyperplasia, because MEN 2A, medullary carcinoma of thyroid, pheochromocytoma, parathyroid. If you are suspecting MEN 2B, which actually carries a poorer prognosis, you have to think of medullary carcinoma thyroid, parathyroid, Marfanoid habitus and ganglioneuroma of the intestine or extensive ganglioneuroma. Familial MTC is only medullary carcinoma of thyroid. Having said that, 80% cases of medullary carcinoma are sporadic, only 20% are familial. However, the patient which you are seeing might not have any family history, but he may be the index case of MTC. So you have to appropriately monitor. What you are going to write in the biochemical evaluation, you will write calcitonin and carcinoembryonic antigen. This calcitonin is actually a marker which indicates the extensiveness of the disease. If the patient is having calcitonin in the range of 200 or 500, you suspect that patient will have lymph nodes. If it is in the range of more than 1000, you suspect that patient may already have distant metastasis. So, medullary carcinoma of thyroid, N0 neck, what you are going to do? I am going to again re-explore the neck. I am going to do the total thyroidectomy along with central compartment neck dissection definitely. Whether I am going to do the lateral neck is controversial. Lateral neck is done only if the value of calcitonin is more than 200 ipsilateral, 500 bilateral. That means if the calcitonin level is more than 200 picogram per ml, you suspect that there might have been unilateral neck node involvement. If it is more than 500, you suspect that there might have been bilateral node involvement, right? Now, coming to second scenario, there is another condition which is recently mentioned in our books, that is NIFTP or FVPTC. What is NIFTP? Anyone? NIFTP. What is NIFTP? You get it in your reports. Non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Non-invasive follicular thyroid neoplasm with papillary-like nuclear features. Whether this is benign or this is malignant, this is actually a benign condition. This term has actually replaced the term which was there few years back, that is follicular variant of papillary thyroid carcinoma. What does this mean? This means that the histopathologist has found that this is a sort of papillary carcinoma. However, the histological structures are suggestive of an absolutely benign finding. That means this case is never going to show lymph node metastasis or distant metastasis, and hence we are going to treat it conservatively. Just like follicular adenoma versus follicular carcinoma, we don't have anything called papillary adenoma, but this is the benign counterpart of papillary carcinoma, which implies that if you are getting an HPE of NIFTP, you are not going to go for total thyroidectomy. Hemithyroidectomy is the end surgery, and you are going to just follow up the patient every 3 months or 6 months, right? So these are the different scenarios. Now, these are points in favor and points against papillary and the total thyroidectomy versus the lobectomy. So what are the indications of total thyroidectomy? NCC guidelines: age less than 15, more than 45 years, if there is radiation of history, if there is known distant mets, if there is bilateral nodularity, if there is extrathyroidal extension, tumor more than 4 cm, that is T3, cervical lymph node mets, that is N1, and aggressive variant. What are the different aggressive variants? Tall cell variant, diffuse sclerosing variant, columnar variant, right? So these are the aggressive variants. These are the features of familial MTC which I have discussed. One thing, regarding the medullary carcinoma of thyroid, as Dipankar Mukherjee sir was saying, there are genetic testings which are available. Now, sir mentioned about 3 things: RET, RAS, BRAF. RET is specifically for papillary carcinoma and medullary carcinoma. RET mutation is 10q11.2, right? Now, now RAS is specifically for follicular adenoma, and BRAF is for again papillary carcinoma. BRAF was found in extensive amount, that mutation, in radiation induced papillary carcinomas. You get BRAF mutation. When you are getting this medullary carcinoma, for specific codons are available which indicates whether the disease is going to be very aggressive or moderately aggressive or lowly aggressive. Codon 918 mutation is considered to be the most aggressive one, and if the father is having N18 mutation, the child has to undergo prophylactic thyroidectomy before the age of 1 year. I again repeat, there are 3 variations. One is, this is some different slide. There are 3 variations. One is highly, most aggressive, moderately aggressive, lowly aggressive. Most aggressive is 918 mutation, which implies that if the father is having N18 mutation, child has to undergo total thyroidectomy before the age of 1 year, because a medullary carcinoma will develop by the age of 5 years, right? So this is about prophylactic thyroidectomy. This was a question given in DNB last year, right? Now, treatment of thyroid lymphomas, anaplastic carcinomas. He has indicated that I have to run it short. Okay. Now, what are the complications of thyroid surgery? Since all of you are going to get this slide, you just go through it. One thing recently has come up. There are certain drugs which has actually improved the quality of life in medullary carcinoma of thyroid. One is levitinib, one is carbozantinib. These are the immunomodulators which are actually responsible for prolonging the life in case of medullary carcinoma of thyroid, so much so that the 5-year survival rate has now increased after appropriate surgery to 80-85%, right? So these are the complications which sir has discussed. This is a case which we actually got. This was a case from my North Bengal Medical College. So this girl had come with this swelling, which was actually thyroglossal cyst. We operated and we found that it was a thyroglossal cyst carcinoma. So what you are going to do? If the patient is having thyroid cyst carcinoma, it obviously implies that malignancy is present all along the tract. So this is not the end surgery. Cyst trunk is not the end surgery, and what you are going to do, if patient is having N0 neck and normal thyroid, cyst trunk will be the end procedure. If however there is any evidence of nodularity, it may not be obviously malignant. There is evidence of nodularity in the remnant thyroid gland, or there may be N+, that is any evidence of metastasis in the neck. You have to go for total thyroidectomy with neck dissection followed by radioiodine ablation and TSS suppression. In this presentation, I have not discussed about the radioiodine part, so I think this is enough. Thank you.